Hello, my name is Lauren Holmes. I'm a PGY4 finishing my OBGYN residency at Ascension Genesis Hospital in Grand Blanc, Michigan. I will be discussing the use of different imaging modalities in acute abdominal pain and pregnancy. Abdominal pain during pregnancy is common with a wide differential diagnosis, including both obstetric and non-obstetric pathologies. Diagnostic imaging modalities used in addition to history and physical exam are often ultrasound and MRIs. This study sought to find the role of these tests in pregnant patients who presented to the emergency department with acute abdominal pain. Previous studies examined the efficacy of MRI as a first diagnostic imaging modality in the setting of acute abdominal pain in pregnancy, concerning for acute appendicitis without conclusive objective findings. The objective of this study is to determine the ability of ultrasound and physical exam findings in correctly identifying renal or hepatobiliary pathology in pregnant patients presenting with acute abdominal pain compared to the use of MRI. This is a retrospective analysis of 136 pregnant women with acute abdominal pain who presented to the emergency department at Ascension Genesis Hospital in Grand Blanc, Michigan from 2015 to 2020. Physical exam, ultrasound, MRI, gestational age, and comorbid conditions, as well as the length of stay were reviewed. Statistical analysis was done using chi-square and t-tests. IRB approval was obtained. This diagram represents the inclusion criteria of the study. 165 pregnant patients presented to Ascension Genesis Emergency Department between 2015 and 2020. Of those, 136 had a chief complaint of acute abdominal pain. 77 charts reviewed had unclear or no physical exam or imaging findings and were thus excluded. Of the 136 patients, 59 underwent ultrasound and 47 had subsequent MRI. 8 had a positive ultrasound for renal or hepatobiliary pathology, and 11 had a positive MRI for renal or hepatobiliary pathology. Our study found that the mean age of the study population was 26.8 years, and the mean gestational age was 16.5 weeks. Of those patients, there were 59 who had an ultrasound and 47 with a subsequent MRI performed. The ultrasound demonstrated abnormal findings in 8 patients for renal or hepatobiliary pathology, with 2 patients demonstrating cholelithiasis, 1 demonstrating choledocholithiasis, 1 with, quote, prominent biliary sludge and small stones, unquote, and 4 with mild to moderate hydronephrosis. The MRI demonstrated abnormal findings in 11 patients, 7 with mild to moderate hydronephrosis, with 1 commenting on, quote, mild perinephric fluid, with the middle 1/3 right ureter compressed between the enlarged gravid uterus and psoas muscle, unquote. 1 with choledochal cyst, 1 with cholelithiasis, 1 with cholelithiasis and a stricture of the common bile duct, and 2 with hepatic lesions. This is a representation of the pathologies that were found on ultrasound and MRI. Of those, 3 underwent a procedure for their acute abdominal pain, including biliary stent placement, ERCP, and cystoscopy with ureteral stent placement. Of those, 3 patients who underwent surgical procedures all had abnormal ultrasound confirmed with abnormal MRI. Previous studies have demonstrated that in the setting of acute abdominal pain in pregnancy and positive physical exam, highly suggestive of surgical pathology, especially in the setting of right lower quadrant pain and suspicion for appendicitis, ultrasound had limited value and patients should proceed directly to MRI for workup and confirmation of diagnosis. This data suggests that ultrasound is in fact an appropriate step in workup with gravid patients with acute abdominal pain, especially with positive physical exam findings including right upper quadrant or CVA tenderness, Murphy or Lloyd signs that are positive as well. Ultrasound is a cost-effective and reliable screening tool for renal or hepatobiliary pathology that is safe during pregnancy. The determination for if an MRI is necessary should be based on clinical suspicion and provider preference. Ultimately, the decision for surgical intervention should be determined by clinical suspicion. Further studies on this subject would benefit from a higher power. Included are the references from this study. Thank you very much.